Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So I was actually going to talk about ICD-10 coding, and I am going to do that next week, but we had some, for lack of a better way to put it, breaking news on the G2211, which is the new complexity add-on code, the HCPCS code that has been giving us all a headache over the last, I guess we're into 8 months of it now. And what the news was is actually finally CMS put out an FAQ sheet, and you can find it at the CMS website, and I'll give you some sites here. But I wanted to go over the Q&A because in case you didn't get a chance to look at it or read it, and you're on your way to work or you're listening wherever you listen to podcasts, I just want to give you some insights on what they're talking about. And it's interesting because, as we know, Medicare doesn't always say no to things. They kind of, I call it Medicare speak, they kind of talk around things. But there's 12 questions and 12 responses to those questions. And as I'm reading through it, and I've read it 3 times, I think there's some interesting things that we didn't know before that I wanted to bring to your attention. So G2211, it's the definition again for those of you who don't know about it. Visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all needed health care services and or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. And this is an add-on code. So some of these questions may think that they're redundant, but if you listen to them, they're actually not. So it's kind of interesting how the response from Medicare comes, and there's citations with each response, so that's actually helpful. So it says, question 1, when can I report HCPCS code G2211? Well, that seems to be the everyday question. It says all medical professionals who can bill Medicare for office or other outpatient evaluation and management visits, codes 99202 to 205, 99211 to 215, may report the HCPCS code G2211 add-on code to office and other outpatient E&M-based codes. It may not be reported without reporting the office visit base code. And again, they reiterate those same codes. And then they cite the 2024 fee schedule, final rule 88 FR 78818. And then it talks about, when can I, so the question going back to it says, when can I report? And it says, you are the continuing focal point for all needed services like a primary care practitioner. You're providing ongoing care for a single serious condition or complex condition like sickle cell disease. It says there are many visits with new or established patients where the complexity visit add-on code would not be appropriately reported, such as when the care furnished during the office visit is provided by a professional whose relationship with the patient is of a discrete, routine, or time-limited nature, such as but not limited to a mole removal or a referral to a physician for a mole removal. So think about that on your referrals. For a treatment of a simple virus, for counseling related to seasonal allergies, for initial onset of gastroesophageal reflux disease, so GERD, for treatment of a fracture. They're considering these to be discrete or time-limited nature. Basically, you fix them and you're done. It says where comorbidities are either not present or not addressed, so it's not going to impact what you're going to do with that patient. And it says and or when the billing practitioner has not taken responsibility for ongoing medical care for that particular patient with consistency and continuity over time, or does not plan to take responsibility for subsequent ongoing medical care for that particular patient with consistency and continuity over time. The thing that I find interesting about this is then why are new patient visits on here? Because you haven't made that decision yet until you've figured out what you're going to do with that patient. So be cautious with new patient visits because I could see them making that a problem later on. Question 2, in what office or outpatient setting can HCPCS code G2211 be billed? Well, to me, that's the same question, but here's something interesting. All rules for reporting office visit services, again, they say the new patient and established patient visits apply to billing HCPCS code G2211. Continue to use codes in this family to report your added-on code if appropriate. It said HCPCS code G2211 is separately payable to the billing physician or practitioner in both facility and non-facility settings, but only with codes G99202 to 205 and 99211 to 215. It also says cannot be billed with code sets for other E&M services such as hospital inpatient or observation, emergency department, home or residence care, and nursing facility. So it's only for office visits. Number 3. Can HCPCS code G2211 be billed when my patient sees another physician or practitioner in my group practice instead of me, including colleagues in the same specialty as me? So here's what's interesting. They could have said yes or no here, but here's their explanation. Answer. In this scenario, physicians and practitioners might consider whether the patient could have an ongoing relationship with the patient care team within the group practice that includes more than one physician or practitioner. We understand it is possible that team-based care practices may also serve as the continuing focal point for all needed services or provide ongoing care for a single serious condition or complex condition. In such circumstances, when a patient sees another physician or practitioner in a team-based care practice, and you've met all the requirements for G2211, it may be reported. So they're basically not saying no, but they're saying we're going to look at this. Question 4, and they talk about the primary care exception. Is it appropriate to bill HCPCS code G2211 using the primary care exception? Physicians can bill under the primary care exception for lower-level office visit services provided by resident physicians in certain primary care training settings. Physicians bill for these services by attaching the GE modifier to their claims for office visits, described by the codes 99202 to 203 and 99211 to 213. The temporary policy we put in place during COVID, public health emergency, to permit physicians to bill under the primary care exceptions for higher levels of level 4-5 visits are no longer in effect. The HCPCS code G2211 add-on can be billed for services furnished under the primary care exception, again, as long as all of the criteria for billing the HCPCS G2211 are met. So you have to consider, is that resident really part of that longitudinal relationship with the patient? Question 5. Can HCPCS code G2211 be billed in an FQHC, which is a federally qualified healthcare center, or an RHC, which is a rural health clinic, an encounter-based rate? It says we generally pay for RHCs and FQHCs an encounter-based rate, so they get a daily rate. The service described by HCPCS add-on HCPCS code G2211 is bundled into all rural health clinics, and it's all-inclusive in their rate or the FQHC prospective payment system. So they're saying there is no separate payment made G2211 for rural health clinics. Question 6. Is HCPCS code G2211 denied when modifier 25 is on the claim for any service? It says as finalized in the 2024 calendar year Physician Final Rule 88 FR 78974 and summarized in the Medler Matters article MM 13272, we will deny payment for HCPCS code G2211 reported with an office visit code that has been reported with a modifier 25 on the same date of service for the same patient by the same physician or non-physician practitioner. For calendar year 2025 in the fee schedule, in response to some practitioners' concerns, we are proposing, now it's not final yet, to allow payment of G2211 when the office visit code is reported by the same practitioner on the same day as an annual well visit, a vaccine administration, or any Medicare Part B preventative service furnished in the office or outpatient setting. So they're saying when the patient comes in, they're there for their well check, plus maybe there's some abnormality found and addressed, and you have a 25 modifier in the E&M, and you still are dealing with the complexity of that patient and what you're planning, then you may be able to get that paid next year if the proposal goes through. What must be documented? Question 7 for HCPCS, for HCPCS code G2211. What does a billing treating practitioner state in the medical record for medical necessity of reporting this code? I hate this question because it's like, what do I need to do to hit a level 5? I don't like this question. And that's basically what they're saying. We have not had any specific additional medical record documentation requirements for the add-on code. But here's what they say, and this is important. It says our medical reviewers may use the medical record documentation to confirm the medical necessity of the visit and the patient-care relationship as appropriate. We would expect that information included in the medical record or in the claims history for a patient-practitioner combination, such as diagnoses, the practitioner's assessment and medical plan of care, and or other codes reported could serve as supporting documentation for billing G2211. But practitioners should consult their MAC, Medicare Administrative Contractor, regarding documentation requirements related to the underlying E&M visit. And they always send you back to the E&M code. So basically they're saying, look at question 1. When would you use it? Question 8. What constitutes a serious or complex condition? What diagnosis must be used? The question must, it should be, could be used. It says no specific diagnosis is required for the complexity code. For the billing practitioner, it would be appropriate to report a health condition that is a single serious condition or a complex condition for which the billing practitioner is engaged in the patient in a continuous and active collaborative plan of care related to an identified health condition of management which requires the direction of the practitioner with specialized clinical knowledge, skill, and experience. Such collaborative care includes patient education, expectations and responsibilities, so that means outcomes, shared decision-making and therapeutic goals, and shared commitments to achieve those goals. So they've again given some examples, as you heard me above, in the context of specialty care. He said, for example, with G2211, this could be billed by an infectious disease physician who is part of an ongoing care for a patient with HIV, or a practitioner who is part of an ongoing care with sickle cell disease. You notice these are not simple diagnoses or conditions. They're really looking for that complex patient. Question 9, and this is a good one because everybody's like, I don't know what this means. What is the definition of longitudinal? Does it matter if the patient comes in once a year, once every other year, or once every 5 years, as long as the patient has selected that physician as their primary care doctor who they call when they need care? So instead of saying no, they're strongly saying, wait a minute. The add-on code, again, G2211, captures the inherent complexity of the visit that is derived from longitudinal nature of the practitioner-patient relationship. Therefore, it's not appropriate to bill G2211, and they underline for emphasis, when the billing practitioner has not taken responsibility for ongoing medical care for a given patient with consistency and continuity over time, or does not plan to take that responsibility for subsequent care or ongoing medical care for a particular patient with consistency or continuity over time. So there's no specific definition of longitudinal, but I'm telling you that 5 years, no. Every other year, I would say no, but you need to have a best practices situation, because I could see them, because of the underlining of saying that if you're not taking responsibility for ongoing medical care in 2 years or 5 years, that's not ongoing, then this may not be appropriate. But they say as long as the practitioner relationship aligns with question 1, again, why can you bill it or when can you bill it? Then it says then it can be recognized that you can enable practitioners to build that longitudinal relationship with their patients to address the majority of the patient's health needs with consistency and consistency and continuity over longer periods of time. So this includes furnishing patients services on an ongoing basis that result in care that is personalized to the patient. So it's hard to really say that you have a personal ongoing relationship with the patient in their complex condition if they don't need to be seen for 2, 3, 4 years or 5 years. It says the services result in a comprehensive, longitudinal and continuous relationship with the patient that involves delivery of team-based care that's accessible, coordinated with other practitioners. They're talking about the broader healthcare landscape for this patient. Does cost sharing apply to this code? Well, you should know this already. This is question 10 for the G2211. Yes. The usual Part B, patient coinsurance and deductible applies when you bill it. So make sure patients are aware of that, especially if they're coming in 2025, if they're going to pass the preventative with the visit and then an add-on complexity code. Patients are not going to be too happy. Can HCPCS code 211 be reported, number 11, during the same service period as care management services, or are these considered duplicative? And this is a good question. So here it says that they can be billed during the same period, but remember, it says we do not believe that G2211 necessarily would be duplicative duplicative of care management, since that concept of inherent complexity is what your professional physician does the work they do during the visit. So when they have the patient in front of them, while care management codes is what happens outside the visit, over a period of 30 days. And then question 12 is just, where can I find this information? So they want cited references. So make sure that you're looking up the calendar year 2024 physician fee schedule 88 FR 78818. And then also look up the Medicare Learning Network Matters article, MM13272, and the new one, MM13473. So also, if you get a chance, make sure you know that in September I've got 2 Medicare updates coming up for 2 different companies, and those are webinars that give you not just this code, because I know you're probably tired of it, but any kind of Medicare updates when we're talking about reimbursement, fee schedules, things that are going to policies, published guidance, and they're both on the 24th. So at 8 a.m. it's the NSCHBC third quarter Medicare update, and at 10 a.m. it's going to be McVeigh seminars. So just know I've got those back to back in September if you're interested in attending a webinar to get all of this in writing. So hopefully you found this helpful. Again, make sure you take a look at this policy. It was posted on 8/22/24, was posted actually today, on the day that I'm recording, which is on the 27th for the 3rd. And so I'm recording early this week, just to get it done since we're coming up on Labor Day. Speaking of which, so everyone, I hope you have a good Labor Day, have something, planned. Hopefully we'll have just a slight dip in temperatures getting into the fall. I've noticed it's getting dark finally a little bit earlier, and we can get into some nice fall weather coming up. So everyone, thanks for listening today. Make it a great rest of your week. Make it a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.